Okay, so I'm Naassif Mohammed. I'm an orthopedic foot and ankle surgeon from Cairo, Egypt. As I said, it's a great honor and pleasure to be with you guys here. So Pete's done a lot of the work on the anterior ligament. These are my disclosures. They do not also have any relevance, I hope, to this talk in particular, but I'm sorry, I do have to put them up. So I think the aim is to talk about the historical background and pathogenesis of anterior bony impingements. Pete's done a great job at talking about the soft tissue side of this, and also give some examples on how to manage these bone spurs, if you will, and maybe there should be more to be investigated or studied, and we'll see how that will appear as we go along in this talk. So going on to anterior bony impingement, it's the ankle sprain. It has been described as the ankle sprain that will not simply go away, and this is possibly after at least people have discussed about this a lot. Maybe it's 3 months, maybe it's 6 months, but it might be a soft tissue or a bony problem. And the funny thing is that some authors have decided that it might be even up to half of these ankle sprains that will still be there. So you have this ankle sprain, but you still have a problem. Now, it has been described ever since, and ever since 1943, it was described in various terms: athletes' ankles, footballers' ankles, and so on and so forth. And as I said, Pete did a wonderful job. He talked about the pathogenesis, mainly about the soft tissue. And this was a recent study in 2018. It was actually in the AJSM. And it kind of tried to differentiate between anteromedial impingement and anterolateral impingement as regarding the pathology, if you will. And the funny thing is that even though they decided that anteromedial impingement, which is mainly a bony impingement, is going to be due to the repetitive capsular traction, as in dorsiflexion motions, but they also found out that possibly inversion ankle sprains would cause both the anteromedial and the anterolateral impingements. Mind you, these are soft tissue and bony. So what about the bony part in particular? Yes, it's the footballer's ankle, it's the impingement exostosis. As opposed to the anterolateral soft tissue impingement, it's usually going to be more anteromedially, probably. There is pain, yes, with dorsiflexion, but it's not only going to be limited to the lateral part, it might be also on both sides. And ever since even the very early studies, there has been this slight instability that has always been described, and we'll come to that a little later. Different also from the soft tissue example is that the bony examples, the bony impingements, they're in plain, blatant view on the x-ray, and you can actually see them. They have been called osteophytes or bone spurs or traction spurs. Now, that, I think, osteophytes is a misnomer, and we'll see in a while. So the anterior bony tibiotalar impingement is more anteromedial. Osteophytes, I think we should scrap that off our list because they're not actually a part, or they should not be actually a part of the osteoarthritic process, though we'll see that in a while and how that differs. They might be more aptly named bone spurs. And as I alluded to, this slight instability, it does play a role, and we'll see, is that we have not, up till this present moment, decided is that the precursor, is that what causes the bone spur, or is it actually as a result of this instability? So traction spurs are more aptly termed, but actually not, because if you look at the osteophytes closely, and anyone who's done these arthroscopically will know that they are actually at the joint line. They're not at the capsular junction, and they're actually slightly above or at the joint line and not at the side of the capsule. So possibly they're not traction spurs. Now, this is even more so for the anteromedial type of these spurs, where the repeated microtrauma results in the healing and the spur formation, but not so much on the lateral side. Now, on the lateral side, possibly because of this microinstability, they might be due to capsular traction or ligamentous traction spur formation. So maybe the traction spurs would be more commonly used for or commonly termed for the lateral sides. And as we said on the radiographs, they're very apparent, and you don't really need a lot to see them. Sometimes they're so apparent they can be anywhere. They can be lateral, medial, they can be anterior. But as you can see, this was a patient that had both sides. And look, there's a difference between the right and the left side as regards the narrowing of the joint space and the osteoarthritis that is accompanying this spur. So which of these is actually going to be the problem? Funnily enough, the patient in this particular case was complaining of his other side, the side that did not have that so much of the narrowing of the joint space. Of course, this has been described. If you do not see them properly, you have a high index of suspicion, is the oblique anteromedial impingement. And Nick Van Dyke, he described this more than 16 years ago, where you take the beam more cephalic to caudate and you externally rotate your foot around 30 degrees, and then that will show you. It has a very high sensitivity. It increases it actually to 85%. And you can see spurs that are even less than 7.5 millimeters. So it's a good view to have in your armamentarium, and you should think about it if you're looking to diagnose one of these anterior bony impingements. And there have been numerous classifications. One of the most commonly used is the Scranton-McDermott, even though it was described way back in 1992. And he described these according to the size of the osteophyte on the tibia and also on the talus, but also if they were both on both sides and if there was fragmentation. Now, Nick Van Dyke himself, he classified again in 97, but his classification, funnily enough, was a classification of osteoarthritis in the ankle joint. And the last two grades, the number 2s, the stage 2 and 3, they were actually not related to the osteophytes. But it has been said that this, of course, has a more prognostic value as regards the osteophytes converging or entering into this osteoarthritic phase. Now, a very nice paper came out from Italy, an Italian group, Parma, in 2014, and they described the osteophytes or the impingements accordingly to A, B, and C, where A is focal, which is involving less than a third of the, whether it's the tibial or the talar side, or wide if it's between a third to 2/3 of the whole width, if you will, of the bone. And they described a certain complex type, which is the type C, which is either multiple, involving both sides, and they put the kissing or the cam lesions as a type C, which is the complex. Now, they even went a step forward, and just using the plain x-rays, they went ahead and described the cartilage involvement, or the osteoarthrosis, if you will. So a stage 0 or a type 0 would be a normal ankle, whereas a type 1 would have a subchondral sclerosis, and then so forth up until a narrowing or a severe narrowing of your joint space into the type 3. And then they decided to put these two factors together, and they came up with this algorithm. So that would be focal, wide, and complex, A, B, and C, and then correlate them with the amount of arthritis, which is a stage 0 up to a stage 3. Now, the indication and prognosis of an arthroscopic management of these cases, the yellow ones, these would be more apt for arthroscopic debridement, and they decided that these have the best. This was a retrospective study from all the anterior bony impingements that they had performed, and they decided that these results they withstand the test of time. Now, if you move one step forward, and if you look at any type of lesion, even if it's a small spur, but it does have some moderate or major degree of arthritis, or if it's a complex lesion, and mind you, in complex, that's also the kissing or the cam lesions, these would not have, they could be treated arthroscopically, but they would not have the reliable durability according to time. And they say that these results they start to regress after a certain period of time. And they absolutely advised against doing any arthroscopic work for those that have any type or degree of moderate or severe arthritis, which pretty much sounds logic, doesn't it? So you can also use other diagnostic measures than just the plain x-rays. Of course, you can use CT. These can pick out the very small lesions if you're absolutely sure that that is the cause. And I would reiterate what Pete said, that you should use these diagnostic infiltration. But for the soft tissue that might be caused by the bony, the soft tissue impingement, but I'm not so sure that we will obliterate the bony part of the pathology. Of course, the MRI, and I think the sagittal T1, I think this also was alluded to by Pete, but it doesn't just show you the soft tissue. You can also look for the bony edema that might be accompanying it. This might also give you a good idea that perhaps it's that spur that is really causing that pain. And of course, people have been using also the ultrasound. It has the efficacy that it's dynamic. Yes, it's operator dependent, but I think that would be more for the soft tissue lesions. So this is a case that had a corresponding kissing or a cam lesion. As you can see, the amount of narrowing of the joint space. But after the debridement, I don't know, the video stopped. Anyway, the articular surface was more or less good. So is this really a complex? If I did this arthroscopically, would I be expecting this patient to deteriorate? This particular patient is now 10 years down the line, and I still have not seen any degradation in his results. other patient. This was actually an national soccer player of ours, and he had what would be graded as a mild form, a grade A, and this was after the debridement, and this was his x-rays. So these was a pretty good cartilage, and he's been doing fine since then. But what about this? According to that particular classification, this is a patient that had the tibial osteophyte. It was beaked, it looked kind of like a parrot beak, and it was eroding the cartilage. So with that classification, he has already progressed to a little bit of osteoarthritis, or is that just the articular bone, the articular cartilage being removed? You burr it down, and we'll get into a technical detail later on, and then you're still left with this, but that's the only pathology on the cartilage. So in that case, I did a microfracture. She's also, I think, 8 years down the line, and she doesn't want to do a second look arthroscopy. She's fine, and she's back to her sports again. A technical note about the burring down, as we said, because they're not traction spares, they're actually below the capsular attachment. So you should burr it down as opposed to up. So you should start with a burr from the top side, and progressively you work your way downwards. Now that has two advantages. First of all, when you're using the shaver, it doesn't suction in the tissues because remember, like Pete alluded to, when you're using the dorsiflexion method, it doesn't suction in the capsule and of course the very vital vascular structures into your burr or into your suction instrument. And also it allows you to see exactly where you need to stop, and we'll get into that a little later in the discussion. The same also applies for the talar parts, the talar neck or the talar osteophytes. These should also be burred down from distal to proximal. It makes more sense, and you can easily define where you need to stop, and we can leave that a bit for the discussion. You can also use a lot of other instruments. In this particular case, I was using one of the rasps from the shoulder guys. You can use a chisel, but you have to be very careful, and I would advise you not to start out if you're just starting out with these with the chisels, because of course they can easily skid off the osteophyte and injure. And if you do that, remember, you might have some loose bodies which you need to remove later on. And that's another advantage, I think, to using the dorsiflexion as opposed to any traction, because if it's enough for the soft tissue that when you distract you cannot really get into the gutters, what about these bony impingements that are just underneath the capsule? So the dorsiflexion does open up the joint. And another thing, if you do get one of these loose bodies, they fall in, it's much easier to milk it, if you will, with the dorsiflexion, which you won't be able to do with the distraction type of technique. So if you do not have an osteoarthritis of the ankle, and you've had just maybe one or more ankle sprains, and this was also another soccer player, and he had this, according to the description of the Italian guys, this was just a simple bony osteophyte. But if you look closely, and I think you can see a little bit of instability there, and actually the part of the superior facet of the ligament is off the lateral malleolus there. And I think you would need to treat that micro instability. So in this case, is the osteophyte the reason, or is it the cause of this instability? We probably don't know till now, and I think we should investigate this further. So this is the bony tibiotalar impingement. But is this the whole picture? Is there more to be learned? We do know that these spurs, they might appear on the x-rays in more than almost half the footballers, and in maybe in 60% of dancers, and they're actually asymptomatic. With chronic instabilities, we can see interior osteophytes in up to a quarter of the patients. In micro instabilities, they have been discussed to be at least 10% of these cases. And they're there, these osteophytes, these bony osteophytes are there. And we do know that they sometimes might recur. Actually, they may be as high as 25%, and they would recur from 3 to 8 years. But when they do, most of them are usually asymptomatic. So you have the bone spur on the x-ray for another possibly sprain or another incident, but the patient doesn't complain at that time of that pain. And these kissing lesions or these cam lesions, they're described now as being complex, and that we are advised that maybe treating them arthroscopically is not as good as we thought they might be, prognostically that is, but is that really true? So this is not just an advocation of what I do, but this is the main, well, if you like, algorithm that I try to adhere to at least at the present time. It possibly will change with future studies or with future info we have. So if the patient has a bony osteophyte, but there is an osteoarthritis of the ankle, I might remove that partially, or considering just removing it partially to maintain the stability of the ankle. But I would rather consider an offloading osteotomy or another osteoarthritic treatment, depending if it's only, for example, medial or lateral. Now, if there is no osteoarthritis of the ankle, I do look very closely for if there is a history of any sprains. Of course, most of us would have had that, but I mean a significant sprain, or if there's any history of instability. And taking that into consideration, if there is no history of instability or a sprain, and I do not see that with the arthroscopy, then I would remove the osteophyte and leave it at that. But if there is a sprain, especially if it's recurrent, I would look very closely for microinstability. And Jordi has taught us a lot about that subject. I would look very closely at the lateral gutter before I even think about attacking the osteophyte. And if there is an instability, I would treat that as much as I could, and then possibly remove the osteophyte with that. So that is the algorithm. I know it's not much, but it's what I am using right now for only those anterior ankle bony osteophytes. So I think in conclusion, these anterior bony spurs, I said osteophytes a while back, and that shouldn't be right, they might point to another pathology. Sometimes, in some cases, it might be just sufficient to deal with just the spur. In other cases, it might be wise to leave a little of the spur, but that's open to discussion. You should look for microinstability, be aware of it, and if it's there, you might want to treat it accordingly. You should be aware of treating out spurs with osteoarthritis, especially in combination, or at least offering the patient that you're going to relieve these spurs off arthroscopically. And I still think there's much room for research. Thank you very much. I need to stop sharing. Hello?
Can you hear me now?
Yes, I can now, Holly, thanks.
Okay, great. That was an excellent talk. Thank you very much.
Pleasure.
Just a couple of questions. When you're doing your bony debridements, do you routinely use x-ray? And if you don't use x-ray, how do you know when you've taken enough bone down?
Yes. Most of these osteophytes, as I said, would be medially or laterally, or in the case they take the whole ridge out. I started off doing using C-arm fluoroscopy. It's there. It just takes a second, and I would advise that, especially for people starting out. But if you do not want to use it, or if you become a little bit more experienced as you go along, what you can see is if you're looking tangentially, because most of us are usually having the scope in the anteromedial border, or vice versa. If you can see right across the ankle, and you can actually see that basset, or the anterior inferior tibiofibular ligament, you can see the joint line. It's right there. It's horizontal in front of you. That tells you that is as much as you should remove. Another point I've noticed is what I personally call the coconut appearance. It's where you remove this osteophyte, and you see that little shell of articular surface in cartilage, and we know it kind of rotates upwards just a little bit onto the rim of the tibia. Of course, obviously, because there's an osteophyte, it's not going to be there. So when you remove the osteophyte, you will see this junction between the cancellous bone and the start of that articular cartilage, and that's where you should stop. That's looking at these tangentially. Now, for the talar osteophytes, or the kissing or the cam lesions, this is a little bit different. What happens is I kind of try to gauge how much dorsiflexion I can get, and that's where I tell myself, okay, it's enough, and I do not think I need to remove more, even though because on the talar neck and body, you kind of don't know where to stop. You do not have a lot of landmarks. It's usually where the articular surface stops. So I would rather gauge it by the dorsiflexion, maximum dorsiflexion under the anesthesia that the patient has.
Do you ever create a trough in the talus? There are some American surgeons I've seen who do that.
I'm not a very big believer of doing another pathology to treat another pathology. So I don't think the talus was created that way. So I would not do it iatrogenically, for lack of a better word. No, I do not have experience with that.
Okay, and one last question for you. You described burring, especially, so for instance, on the tibia,
Yeah.
from superior to inferior. I think, when I'm teaching residents and fellows, I usually have them start inferior?
Um, that that is a very good technical point. I'm not sure. There's no. I don't think there are many ways, as we say, to do this. But I think it's much safer, especially if you're starting out, to get the edge, the superior edge. We do know by pathology that the capsule is still way above us. Well, not way above us. We're talking millimeters here. But I would rather have the burr pointing downwards. You know these suction. We use a 4.0. And even if you are not, the suction, because you're going to be burring, there's going to be debris you want to see. I use the suction intermittently. I would be more afraid of it suctioning in the capsule and, of course, the neurovascular structures than me removing less of the burr. So I don't know if it makes sense, but no, I would still rather start from top to bottom.